Madam, we are going live now. So, good evening, all. Myself, Dr. Meenakshi Pure. I'm a Chief Coordinator of NMDF. On behalf of Navi Mumbai Doctors Foundation, I welcome you all for today's 1:39 p.m. In our family practice, we come across with some very common complaints like headache, giddiness, blackouts, unconsciousness, and many times patients themselves give us diagnosis of these complaints like exam tensions and emotional nature, maybe some family disputes, etc. So these complaints may be of some neurological in origin. And one or 2 months back, I had one patient, 23-year-old girl, underweight, married, and used to have weakness, blackout, unconsciousness. And her mother used to tell me about this girl. It's like she was having. Can all hear me properly?
Yes.
I'm just requesting whoever mic is on, please make it or keep it on mute, please. So with this complaints, many a times patients come with us and they want to have a perfect diagnosis and perfect treatment for them. So in this case, I was very much worried about that girl. I convinced her and I asked her to consult Dr.Aarti Kulkarni madam. So after consulting her with the right diagnosis and treatment, now she is doing very much better and she is very happy with the complaints also, and she is totally cured of these complaints. So many times this happens with us, right? So let's clear out concepts of diagnosis of neurological complaints with very eminent speaker with us, who is Dr. Aarti Kulkarni madam. Warm welcome to Dr. Aarti Kulkarni madam. So Dr. Aarti Kulkarni madam is a consultant neurophysician, MBBS gold medalist, MD general medicine gold medalist, DNB neurology. So we have a golden lady with a golden treasure of knowledge. So Dr. Aarti Kulkarni madam is attached to Apollo Hospital, Belapur. She is attached to Terna Hospital, Nerul. She is attached to MGM Hospital, Vashi, MPCT Hospital, Sanpada. So she is also running her own clinic very successfully at Kharghar. The clinic name is Aarogyam super-speciality clinic with the facilities such as EEG, Botox and NCV EMG. Now I request all the participants, a gentle request to all, please keep their videos off and please keep their mics on mute. I also request all the participants to ask their questions or post their questions in the chat box. The questions will be answered at the end of the session. So on behalf of all the participants, I welcome again Dr. Aarti Kulkarni madam, and I request you to start the session. Thank you so much.
Thank you, madam. Thank you very much for such a lovely introduction. And I would also like to thank Navi Mumbai Doctors Association for giving me this opportunity. This is my second session with them. And in the first session, that was a huge response which we got. We had discussed initially about a few common cases like epilepsy, headache patients, migraine disorders, how to identify them and how to treat them. So just to go ahead, today is the part 2, maybe the session 2 of discussing common neurological cases, those who come across in the routine, we come across those kind of patients in our routine OPD practice. So today I'll be discussing only 4 cases and basically how to approach such kind of cases when such kind of patients are coming to your OPD and they're telling you your symptoms. So approach to acute onset of weakness. So 35-year-old male is an alcoholic and smoker, presented with history of acute onset of left side numbness and the weakness since 3 years. He did not have similar complaints in the past. On examination, his pulse rate.
Slides are not seen, madam. Slides are not seen. Put the slides on.
Is it visible now, sir?
Yes, madam. Yes, that's fine.
Okay.
Now
fine, no problem.
make it on the slide show full screen.
Yes.
Right?
Yes,
Yeah.
yes, definitely.
Right. Right. Thank you.
Now?
Yes, madam.
Okay, thank you very much. So this was I think this was 1 year back. This patient had come to my OPD with history of one-sided weakness, left-sided weakness, and the numbness since 3 years. He did not have similar complaints in the past. The wife told me he is an alcoholic and he's smoker also. On examination, his BP was on higher side, that was 180 by 90, and his sugar was 97. Rest of the neurological examination, I'll show you the video, and we will discuss. So such kind of complaints, any patient is coming to your OPD, what we think of. So whenever such kind of patients are coming to my OPD, I always think of possibility of stroke since it is acute in onset, and that too this patient is telling me the onset is since 3 years. Then definitely my heart rate has to run and I have to do things in investigations at the faster rate because he is in the window period for stroke thrombolysis. So when I saw him, this is the patient's wife is also there on the this. So we can see what are our examination finding, clinical findings. So I'm asking him to keep his hand outstretched. So I'll play this video again. This is nothing but so looking at the video, we'll get an idea that definitely right hand is normal. The left side he is having a problem. What test we are doing, that's nothing but the pronator drift sign. That test will give you an idea whether the patient is having anything which is cortical or a means if the brain is involved or maybe pyramidal tracts are involved or not. So whenever any patient of acute onset of stroke, when you are not sure clinically, we are dealing with a mild stroke and the weakness is not able to assess, that time you can go for a pronator drift sign. So in that pronator drift, the patient's arms are outstretched. The moment he closes his eyes, the hand gets pronated. Now we are asking him to supinate his hands. So the moment he closes his eyes, the hand gets pronated. At the same time, it gets flexed at the elbow. So this is called pronator drift sign. That will tell you the neurological insult is there or not. So most of the time we tell nahi kuch tensions ke wajah se hoga, maybe cervical spondylosis is giving you this. No, nothing of that sort of. Moment pronator drift is present, you are dealing with the case of stroke. You have to investigate this patient, especially this kind of a mild stroke when the power is 4 plus or maybe a 3 plus. So that time this sign is useful for you. Otherwise, we end up telling the patient, no, it could be because of the tension or maybe you have worked so much, could be just because of the high blood pressure, and we just try to regularize his BP and we give him BP medication. No, nothing of that sort of. You have to send this patient to the stroke ready center since he has come within the window period of 4.5 hours. So next what we did, we shifted him to stroke ready center. So why shifting patient of window period to stroke ready center is important? Because we have to understand this pathophysiology of brain. This is a unique pathophysiology which is found only in brain, not in any other organ in the body. So if any blood vessel is getting blocked and the blood supply is getting arrested, what we get something called as infarction. So what we are seeing in the first image in 30 minutes that the black color area is infarcted area, and we have something called as a blue color area, which is nothing but the penumbra. So the aim of neurologist is to save that penumbra, and we have to treat those patients as early as possible within the onset of 4.5 hours from the onset of symptoms, so that much of brain parenchyma is salvageable. That is not infected area, that is oligemic area. More and more we wait, that blood circulation to the oligemic area also becomes zero. and the neuronal damage becomes more. So that's why the thrombolysis of acute window patients is very much important, rather than just telling them it's just a mild stroke, don't do anything, just take ecosprin and aspirin. So we'll just discuss about acute stroke patient, what has to be done. Definitely you will have to refer patient to the stroke ready centers. So you should know first of all which are the stroke ready center. Nothing of that sort of, you don't tell patient to do MRI, to go and to check the blood pressure again and will regularize the blood pressure. Nothing doing. We are sending patient to stroke ready center. Which are the stroke ready center? Vashi, we have Fortis, we have MGM Vashi, MPCT Sanpada, Terna Hospital, Apollo Hospital. These are all stroke ready centers. So, or MGM Kamo on the Panvel side. So there you have to send the patient saying that patient is within the window period. Kindly do needful. So what has been done? As soon as the patient comes, we take a vital of the patient, we take sugar, and we shift patient to CT scan. Once the CT scan has been done, if the patient is having ischemic stroke, the most of the time, if he is in the window period, the CT scan is normal and the patient has a paralysis. We do CT scan to rule out possibility of bleed. The moment bleed is not there, we consider eligibility criteria for IV stroke thrombolysis. So what are the eligibility criteria? If the age is more than 18 years, patient is having neurological deficits, onset is within 4.5 hours, and the CT, which is non-contrast CT scan, is not showing any bleed or any large infarct. These are the contraindications. So any person who is thrombolizing such kind of a patient should be aware of the stroke should not be very big. The patient should not have ICH, intracranial hemorrhage, or subarachnoid hemorrhage at the same setting. The BP should not be very high, 185 by 110. Patient should not have any intracranial neoplasms like brain tumors, any aneurysms or vascular malformations. There should not be any active internal bleed. Like some patients, they have active pile bleeding is going on. So in such cases, we have to think, we generally don't thrombolyze such kind of patient when the patient has active internal bleed from any body orifices. Patient is having bleeding diastasis and the coagulopathy. A patient who is already on the anticoagulant. So such kind of patient generally we don't thrombolyze. If the sugar is on the lower side, patient is having GI bleed within the 3 weeks of onset of symptoms of stroke. Any major head trauma and the symptoms are consistent with aortic dissection or endocarditis. These are the contraindication, and depending on which neurologist we take a decision whether to thrombolyze the patient or not. So we have to be, we need to have an inclination towards the thrombolysis, especially when all these contraindications are not there. Because we have seen the recovery of the patient, it's an evidence-based recovery. If we are thrombolizing, the functional outcome of the patient is much better as compared to just giving ecosprin and heparin to the patient. So this is what we follow. Of 1 to 3 hours, we give alteplase or tenecteplase. Patient is coming a window period of 3 to 4.5 hours. And provided patient is not very old and it should not be a big stroke with the NIHS score of more than 25. Patient is not on oral anticoagulant, then we consider giving patient alteplase. Only 2 drugs are approved, unlike myocardial infarction. In the stroke, in the cerebral ischemia, we have only 2 drugs, that is tenecteplase and the alteplase. The dose of alteplase is 0.9 mg, dose of tenecteplase is 0.2 mg per kg of body weight. That too after taking written informed consent from the patient's relative. So this is about stroke. If the patient is out of window period, then the question of doing all this exercise does not come. So at that time, we just ask them to get an MRI brain plus angio. We look at the vessel status. We look at the comorbidities. We try to look for risk factors. Accordingly, we treat patients with antiplatelets and statins. So when it comes to stroke, your time matters. The time is brain, because more time or a delay in the treatment of stroke patient, those who are in the window period, more and more neurons die, more and more synapses, they go dead, and the patient's recovery gets delayed. So how to identify stroke in our OPD practice? Any acute onset of facial drooping on one side with the arm drift, weakness of the hand, difficulty in speaking, and the time period for us should be less than 4.5 hours. So we have to act fast. We have to tell patient, this is the symptom of stroke. He has to go to stroke ready center for stroke thrombolysis. SOS, we can also take an option for mechanical thrombectomy for such kind of patients. Next case. So this was the patient when we did his MRI after thrombolysis. We had done his thrombolysis. So you can see here he had a pontine infarct. So basically it was hypertensive infarct that was into the pons. You can see here my arrow. So it was basically on the right side of the pons and the patient got a weakness. So case 2, this is also my OPD patient. How to approach a case of dysphagia. So 53 years old female. She initially started with the complaints of difficulty in swallowing solids as well as for liquids. Initially, solid difficulty came first. Later on, the difficulty also developed for taking liquids. So while whenever she used to take anything, she used to have recurrent episodes of coughing and the choking episodes while eating. So for that purpose, they had shown to multiple ENT surgeons. The multiple investigations were done over a period of 3 to 4 months, like video laryngoscopy, CT, neck. The patient also developed weight loss, thinking that the relatives thought she is not eating, because of that she is losing weight. So that's why upper GI scopy was also done to look for any GI cause related to the dysphagia like GERD and all. Patient underwent whole body PET CT, that was also normal. And maybe one of my patient also, maybe at last option was me left. Maybe one of my patient told them better to say Dr.Aarti, she will at least assess and she'll tell you what is required in your case. That's why they had come. They was patient was not referred from any other doctor. Patient was referred by one of my old patient. So this is the video. You can see here, and just you can make out your observational finding also. Does this video is visible?
No, madam.
There is one more. You can see, you look at her tongue.
We can't see. We can't see, madam. Video is not seen.
Is it visible?
No, no, madam.
1 minute.
Yeah.
Now?
No, madam.
Is it visible?
No, madam. No, no.
Now?
I think now you can play. The list is seen, but
Maybe some. Now?
no, madam.
The PPT is visible?
No, you have come to your, I think, desktop screen.
Yeah, so basically, this patient had tongue fasciculation. Along with that, she had a restricted movement of the tongue. And if you could see the first video, she had difficulty in speaking. Her voice was also not clear. What we call that as a spastic speech. So the problem was not related to the ENT or upper GI system. The problem was more of, it was in relation with the brain. So what we call that condition as bulbar onset motor neuron disease. So bulb for us is oral cavity, because in the brainstem, 9, 10, 11, 12 cranial nerves which are there, they're originating from the brainstem. And then they form the bulbar structures that we call as a bulb. So any involvement of those structures because of neurodegenerative disease and the loss of neuronal cells over there, giving rise to a condition which is called as bulbar onset ALS, that is amyotrophic lateral sclerosis, or nothing but the motor neuron disease. So diagnosing motor neuron disease for us, it's like giving a death sentence to a patient, because we
Our
know
colleagues,
there is no life expectancy. Generally, patient can survive up to 3 to 4 years, not more than that, once we diagnose a case of motor neuron disease. And we have very limited medical options, also medicine options for treatment of those. And those are there just to prolong the patient's life, maybe for another few months, not more than that. But we diagnose patient early in the course of the disease because those treatment options are available. Moment the patient goes into the advanced stages, we cannot offer them those medicines also. So seeking the help of neurologist is very much important for diagnosis as well as prognostication. Prognostication of disease is very much important. For example, if when I come across any neurodegenerative disorders or many advanced cases of dementias or Parkinson's plus syndrome, that time maybe a counseling of relative plays a very important role. What is important from neurologist point of view, or maybe any person perspective point of view also, is the functional status of the patient. If the patient is not functionally good, or maybe he is just dependent on the family members, it is very much important to tell the relatives that the disease is progressive. We cannot do much for it because we don't have treatment options available, and it is neurodegenerative disease. So in case future on, if the patient requires any ventilatory care or any advanced care, just to withstand or maybe to keep his uh, uh, keep his just to keep him live, so that time not to go for such kind of options like keeping him on a ventilator for a prolonged time, because the quality of life is not good. So that counseling we do in the subsequent session once the patients develop adequate trust on us, once they accept the diagnosis, and once they are ready to act on our counseling. So this is the case too. So whenever it's a dysphagia, you just never don't think of it just a ENT problem. There could be a hidden neurological cause behind it. A certain treatable causes also in the neurology, which can present to you with the dysphagia, like bulbar onset myasthenia gravis, which is potentially treatable disorder. We need to find out, we have to treat, and patient gets recovered 100% if you're identifying and treating them as early as possible. Case 3.
Madam, your slides and video are not seen at all. Only your voice was heard for last 5 minutes. Last 5 minutes, only your voice. Nothing was seen on the screen.
Okay.
No, your desktop screen is seen, madam, but the videos and presentation, I think, just try to.
Now?
Yes. Now the presentation is seen. Case 3.
Case 3. So we will go with the case 3. This is a 24-year-old male patient. He is resident of West Bengal. He presented to me with a multiple joint pain, muscle pain, and the body pain since 4 to 8 weeks. And he also developed during this episode of illness, he also developed episodes of palpitations and the sweating. He had shown to multiple doctors as his native place. Later on, his sister brought him here for further investigation. So, any patient of multiple joint pain, muscle pain, body pain, when it comes into the picture, we always think of possibility of arthritis into the picture, and we look for a causes of arthritis. So there are different causes we can list upon, that is mentioned in the next slide. But whenever we think of arthritis, we also look for, is any other system is involved besides a musculoskeletal system? Is any nerve axis is involved, cardiac system is involved, patient is having underlying neuropathy or not, or maybe any skin changes or not. That needs to be seen on for all the patients, those who visit you on the OPD basis. This patient also developed fever 2 weeks prior to coming to my clinic, and it was a high grade fever of 103 to 104. So what are the possibility which you can think of? So either you can think of infective causes post-viral maybe, or viral prodrome during the viral event the patient is getting this, or maybe the autoimmune conditions are giving rise to this kind of phenomenon. So when he came, I just thought of possibilities. Either it is inflammatory. So inflammatory, we think of either the seropositive, seronegative, infectious, or a crystal induced. Like seropositive, we think of rheumatoid arthritis, lupus, scleroderma, vasculitis, CN-CUP, PN-CUP, Sjogren. Seronegative, we can also think of ankylosing spondylosis because he's a young male. Psoriatic arthritis, reactive arthritis, inflammatory bowel disease, infectious diseases like post-viral, bacterial infection. It could be tuberculosis infection giving rise to all kind of symptoms, or it could be crystal induced like gouty arthritis or a pseudo gouty arthritis. But being neurologist, why am I talking about joints? because sometimes we think we have referred to whom to refer a patient, especially when there is a multi-system involvement. But I feel it would be better as a clinician or maybe a physician for a neurologist to interpret and to get the entire picture of the patient. The neurologist can understand it better and can help the patient to diagnose and treat patients accordingly. But this patient, when he came to me, he had the clinical picture of this. I will just show you the slide, this picture. 1 minute. Is it visible? The video slide screen is visible.
Video slide is visible.
Now the video is visible, madam.
Just try to play it. It
Yeah,
is
I'm
not
playing.
visible. No, it is not visible, madam. I think
1
you have
minute.
to go to the video
I have
settings.
to escape maybe and then.
Yeah.
1 minute.
You click on videos, the arthritis.
Now, madam, visible है क्या?
No, madam. No, madam.
Maybe थोड़ा सा.
मॅडम व्हिडिओ प्ले होत नाही.
स्क्रीनवर मोर मध्ये जाऊन मॅडम काय करता येते का बघा.
बरं.
मोर आणि व्हिडिओ सेटिंग्स मध्ये. Yes, now it is visible.
So what are your observation finding in this patient? So I will play this video again. Yes. What are your observational finding? So this is the last video, so anybody can answer, no problem.
Tremors
Is
in the
it
right
Hello.
hand.
Hello.
Wilson?
Hello.
Drug induced or Wilson?
Hello.
Yes. Yes.
Hello. Can I speak?
Yes, madam, please. Yes.
Yeah.
Yes.
One is pronation, one is supination. One hand.
Okay. So, looking at the picture, means patient had arthritis, fever, and palpitation.
Korea.
Yeah, very good.
Rheumatic Korea.
I was just waiting for it. Yes, very good. Really, I do appreciate it. It's Sydenham's Korea. I really appreciate your efforts because the constellation of clinical findings and the picture is very much important. If you'll go back, if you'll understand the overall this video, he's having some slow writhing movement, which is like dancing movement of the right upper limb. But I have put the video in his leg also. He's having similar movement in his right leg, and it is right more than the left. So that was the rheumatic chorea. It was nothing but the Sydenham's chorea. So, which was causing all these problems.
Can you show it again? Can you play it again?
I referred that patient to. Yeah, yes, please. I'll do it again.
Yeah, please do it. Yeah.
Is it visible, sir? So you can see that slow dancing movement of the right upper limb, especially fingers. It is also there in the leg.
Dancing movement of the upper limb.
Yes, madam. Yes.
So this was nothing but the Sydenham's chorea. So I referred that patient to cardiologist. We got 2D echo done. 2D echo was suggestive of rheumatic involvement of mitral valve as well as aortic valve, severe mitral regurgitation. We started patient on rheumatic fever medications. That was we give high dose of NSAIDs like aspirin to such kind of patients, as well as we give penicillin injections, and or we can give also go for oral penicillin formulation. When it comes to treating a neurological part of chorea, we generally prefer giving haloperidol to patient. That is nothing but the Serenase along with the atypical antipsychotic we can also use with high doses of steroid if required. Like we can also give MPS or deflazacort or Visolon as per the patient's neurological manifestations. And finally, we treated that patient. Patient recovered. We gave him cardiac medication, also heart rate stabilizing medications. So the episodes of that pounding heartbeat and the palpitation was related to more of a cardiac arrhythmia during those episodes with the sweating. And we could treat that. Then patient recovered completely because Sydenham's chorea is 100% treatable disorder, but it takes time for a recovery, maybe 4 to 6 weeks, depending on the medication uses. And we have to give anti-inflammatory medications like NSAIDs and steroids also for such group of patients. So this was one of the part for movement disorder. And such kind of patients in rural setting, we do see very often, but in urban setting nowadays, we are not seeing. Maybe in last 6-7 years, I have seen maybe 1 or 2 patients like this, and we could diagnose and we have treated such kind of patients. Last case. Last is approach to headache and giddiness. So 61-year-old female, she was referred to me by an ENT surgeon. Patient had a giddiness. Along with that, she had a runny, sticky nose. And for that, she went to ENT first, and later on, she was referred here. She was obese patient. She had a weight of 130 kg. And she, on asking repeatedly, she also said she had episodes of fever with headaches, with giddiness, with this runny nose. So when I checked her, I got a neck rigidity, but there was no neurological deficit. So any patient of headache comes just to look for a red flags. You have to ask any patient, elderly patient, more than 50 years. That is itself is a red flag for doing any neuroimaging. Second red flag, whether the headaches are very severe in intensity, that is associated with the nausea, vomiting, confusion, any loss of consciousness, that is the red flag. Patient is having any visual disturbances for a new onset headache, older population, and maybe any vision defect during that time, again, you need to do a neuroimaging for such kind of patients. And fourth and most importantly, if fever is running in the background with the headache, you'll have to do the neuroimaging if the patient comes to you with a history of headache with the fever. But at the same time, the clinical examination in the neuro is must. You have to look for neck rigidity. You have to look for other signs of sickness, like patient is having low blood pressure, increased heart rate, that you need to see. So when I saw her, I asked her to get MRI. MRI was not possible in most of the center because she was obese patient. So finally, we could manage that in the bigger center. So MRI showed leptomeningeal enhancement. And whatever sticky discharge, what she was telling was from the nose, that was nothing but the CSF rhinorrhea, because we could found the defect in the dura during the MRI images. We got the defect in the dura, and that was the reason for getting CSF leak. And that was responsible for giving rise to bacterial meningitis in this in her. So when we did CSF, the cells were more than 1,000 with the high protein and the low sugar. Rest of the examination in CSF was normal. It was negative. Gene export was negative. Malignant cells were negative. Culture for TB culture was negative. Bacterial culture was also negative. So basically, CSF leak was giving the access for multiple this bacteria and all to enter inside in the brain, and that was giving rise to the leptomeningeal enhancement and the bacterial meningoencephalitis. So this was the MRI picture. So in this, you can see the lateral part, basically the dural involvement and the dural thickening is also there with the leptomeningeal enhancement. And that is there mainly on the temporal side of the brains. And you can see here the vessels are also prominent in the scan. So, but she deteriorated very fast, and because of the infection. and next day she got intubated. So we had to do dialysis because she had a renal shutdown. Secondly, to sepsis, we have to increase her antibiotic dosage, and the upgradation was of antibiotic was done that time. And over a period of time, we could extubate her. So she was managed from GCS of almost 3 when she was not speaking anything, not responding, not opening eyes, but intubated to GCS of 15. Now she is coming regularly for follow-up in the OPD. So luckily, patient got referred to a correct doctor on time. And such kind of patient, basically, we require comprehensive care when we have to manage this patient at the tertiary care center. The learning point in this patient was like she was a pretty difficult patient to understand because she had obesity that was giving rise to idiopathic intracranial hypertension. So in obese patient, what we get an entity of IIH that is giving rise to high pressure in the brain. But if the pressure is not treated and if the patient is not taking any medical help, at time the increased pressure in the brain, it gets leaked from the dura. Sometimes patient can have CSF rhinorrhea because of the spontaneous dural leaks. So she had that. Once she got a spontaneous CSF leak, from that CSF leak, she got a bacterial meningitis. And we treated that bacterial meningitis. Repeat MRI when it was done. Patient also had a features of when we analyzed that MRI again and we compared that with the first scan, we thought of possibility of IH. So the main line of treatment for her is to reduce the weight. So now she has lost almost 35 kg of her weight. She's 95 now. She is still under my care, and the aim is to keep patient's weight within the body mass index as per her body weight, body height. So she's coming for follow-up and she's doing good so far. So this is about 4 important cases: giddiness, weakness, and the movement disorders which I have discussed. So if any question from your side, you can ask anybody from the participants. Thank you very much for giving me an opportunity.
Madam,
Thank you, madam. Thank you very much. And I will just see if there are any questions, or if anyone wants to ask directly questions, you can unmute yourself and ask.
What is, madam, how to
Madam,
do this
can I ask a
pronation test?
question?
Pronation test you advise in the beginning. Pronation test, hand movements. How
So
to do
in
it
our
again?
busy clinical practice, we have to do the pronator test for all suspected stroke patient or acute onset of weakness. Pronator drift we can on the basis of pronator drift we can localize also, sir, because moment the patient raises his hand and he closes his eyes, if you're getting a pronation, we think of a possibility of a stroke which is involving the pyramidal tract. Sometime when the patient closes his eyes, his hand can go up also. That is because of the parietal lobe involvement, and the stroke could be possibly in the parietal lobe. Sometimes the hand sways like this. That swaying is also seen when the patient has ataxia in the background. So the small ataxic strokes can also we can pick up by doing the pronator trips. So that is very useful clinical sign to check on the OPD basis. That will tell you whether we are dealing with a stroke patient or a pyramidal tract or a brain related structures are involved or not.
Can I ask a question, madam?
Yes,
Yes,
please.
yes.
Madam, can you repeat the case number 2 very fast? It was an interesting case. We couldn't see the slide also.
Right.
If
So
possible.
yeah, no problem, sir. I will just go to the video and I will describe at the same time. Is the video screening is seen on the slides? Maybe is it seen,
And
madam?
list of videos is screen on the desktop. Just try to play. Let's see.
Now?
No, madam. Try in video settings. Zoom video settings.
आता दिसतंय मॅडम?
नाही.
आता
Yes.
दिसेल आय थिंक.
Yes. We can see. Play नाही झाले.
आता
Yes.
see, she cannot put her tongue to her upper palate. And look at the tongue. Patient is having fasciculation also. The tongue is atrophic with the limited motility of the tongue. So normally a normal person can touch the tongue to the palate. As at the same time, we can put our tongue up to the maybe a chin level and up anteriorly above up to the philtrum of the nose. So in this case, it was not possible. And she similarly also had fasciculations. Cannot go up. Going up is not possible. And these are the fasciculation, what you can see in the tongue. And this was the spastic speech. So this was the case basically.
One more question, can I?
Yes. Please.
Madam,
yes, sir.
when do you ask for biofire in meningitis cases?
Yeah, biofire is basically, sir, we have biofire for viral, it is different. Bacterial is also there. If the most of the setting when the patients are affordable, we go for biofire because the test is very costly, up to 25 to 29,000. But whenever the clinical suspicion is adequate enough to tell us it is bacterial, we generally go for directly bacterial culture. Viral, whenever we are thinking strongly a possibility of different viruses, that time we go for a viral biofire. And in fungal cases, generally we don't do. We directly go for cryptococcal or any candidial meningoencephalitis is there or not. So basically, patients' affordability criteria and clinically, when we are not sure what we are dealing with, that time only we go for biofire test.
Madam, what are the red flags in vertigo? Because some patients are having diabetes, hypertension, coronary artery disease, and in them the vertigo is there. So how to differentiate whether it is a dangerous sign or just vertigo? I mean, tympanitis or like that.
Yeah, right. So I will just give you 4 clinical clues on the basis of which you can diagnose any vertigo patient. So if the patients are coming to a OPD, maybe you just need to spend 5 minutes extra. So you ask them first describe their vertigo or giddiness, what they're saying. So for some patient, the giddiness is just a swaying of the body. ऐसे thoda sa hilta hai, body is giddiness. Some patient might tell you it is like rotatory sensation. Surrounding is moving and it is moving at the faster rate. It is lasting for only for seconds or a minutes or maybe hours. So when external surrounding is moving, it is a vertiginous sensation. We label that as vertigo. Then we have to ask next question. It is there since how many years or it is new onset और बीच-बीच में आके जाता है कि बीच-बीच में एक साल में एक बार हुआ, 2-3 बार हुआ. It will last only for seconds, that you need to ask. If the patients are saying it is there since many years, but it is lasting for hours together, during that time the patient might not feel good, some depressive symptoms, some headache is going on in the background, then we are dealing with a vertiginous migraine. Second, if it is lasting only for seconds, like body movement se ho raha hai, right side pe soenge to zyada chakkar aa raha hai, I'm feeling very much anxious during that time, or a patient is really frightened during those episodes with severe nausea, vomiting, it is there since many years, or maybe it could be acute in the onset, then we are dealing with the PPPV, that is benign positional postural vertigo. If the patients are saying it's last started after the viral prodrome, then we are thinking of possibility of acoustic neuronitis, or maybe a viral neuronitis involving the 8th cranial nerve structure, like which I thought of that obese patient possibility, because in MRI she had a involvement of the auditory nerve also, but along with that she had a meningeal involvement. So vestibular neuronitis is basically a post-viral involvement of the 8th cranial nerve. If it is not vertiginous, then your differentials are different. Like the patient is saying, "Sirf body aise move karta hai, but I'm not feeling vertiginous sensation." Then again you have to ask, it is there since many years, as then is it a postural thing? So in old patients, generally you have to look for any postural drop in the blood pressure. So orthostatic hypertension, if the BP medication dose is more, so sometimes on particular posture they will feel the body swaying. Like today I saw one patient, the patient had some abnormal sensation on standing, and he used to feel like his legs are moving during that time and loss of consciousness. So are we dealing with a pre-syncope or a syncope type of condition in which the patient is having giddiness? So that giddiness will not be vertiginous, and it will come only for a second. Patient will have loss of consciousness, they will recover. Third thing most important in giddiness when it is not vertiginous is you have to look for, are there any pyramidal, extrapyramidal symptoms in the patient? Like Parkinson's patient, those who are having Parkinsonian features, they have giddiness throughout their life because the postural reflexes are not corrected. So moment they'll walk, their walk is not steady and they'll feel like the body is swaying. There is type 4 giddiness for neurologists. It is a functional giddiness. When we rule out all the possible causes of this giddiness, then we think of fourth cause, provided all neuroimaging is normal, that is functional giddiness. Like some patient will say the giddiness is there throughout the life. बैठने पे भी होता है, सोने पे भी होता है, female patients में ज्यादा हो रहा है, emotional triggers are there, and the attention seeking behavior is there. That is a functional giddiness. So this is the way the commonest OPD practice, on the basis of our OPD practice, this is the commonest way by which we can differentiate the type of giddiness. Which giddiness we have to give more importance to, which is acute in onset, associated with any weakness, any visual symptoms, like giddiness with squint, acute onset, giddiness with a severe headache, and along with that visual disturbances, swallowing difficulty, any paralysis on one side of the body, and giddiness is severe enough to compromise patients' day-to-day activity. Such kind of giddiness we definitely need to pay attention to, because definitely we are dealing with some organic conditions over there, and we have to investigate such kind of patient if it is acute in onset. If the patient is saying it is going on since 10 years, bouts are, then no need to raise your BP. You can just simply investigate and you can treat those patients on the OPD basis.
Thank you very much, madam. What
Thank
about
you, sir.
nystagmus? Nystagmus, madam. What to see in that nystagmus?
Yeah, for nystagmus, about nystagmus, I can talk about 4 to 5 hours only on the nystagmus, because see, when the nystagmus comes into the picture, either we are dealing with the vestibular auditory system, or we are dealing with the posterior part of the brain, from where the auditory nerve comes into the and it supplies your structure. So basically, either we are dealing with the cerebellum, we are dealing with the brainstem, or we are dealing with the vestibular cochlear apparatus. So we see the type of nystagmus. So if the patient is having horizontal nystagmus, which is a gaze evoked nystagmus, or if on central fixation, moment patient is fixing and still the nystagmus is present, means you ask patient to look at your finger and the patient is looking at your finger and still the nystagmus is there, then you are dealing with the central nystagmus that time. You have to be very careful. You have to ask for brain imaging. But the nystagmus is present. It is positional nystagmus associated with a very severe nausea, vomiting. So the likely possibility is that you are dealing with a peripheral vertigo. Most possibility of that is could be a benign positional postural vertigo. During that time, we do Dix-Hallpike test and we correct that. But the directional changing nystagmus, vertical nystagmus present on fixation also, then you are dealing with the central nystagmus. Then you have to investigate such patients by doing neuroimaging and the detailed clinical examination.
Thank you very much, madam.
Ma'am, how to deal with slow onset stroke?
Slow onset. There is no such entity called as slow onset stroke. Stroke like the stroke is होणार, एकदम stroke करूनच येणार patient.
Evolving stroke, evolving stroke.
Yeah, it's a good terminology, evolving stroke. So if you are dealing with the evolving stroke, तरी पण विंडो मध्ये असेल तर स्ट्रोकच्या सेंटरलाच पाठवायचं. If the patient is within the window period of 4.5 hours, you don't have any OPD basis treatment. You have to refer patient to stroke ready center. पण इव्हॉल्विंग आहे आणि पेशंटला 6-7 तासापासून आहे. Better to do the urgent MRI imaging of the patient with the angio, and then you do needful for the patient. If the major vessel occlusion असेल, तर we can still have an option of mechanical thrombectomy. If major vessel occlusion is not there, then we have a medical options. So better to admit such group of patients and you treat them with the maximum antiplatelet and anticoagulation cover as per their diagnosis.
Ma'am, how to differentiate CSF rhinorrhea and simple rhinorrhea?
CSF rhinorrhea from
allergic rhinitis.
CSF rhinorrhea from allergic rhinitis. Okay, very good question. CSF rhinorrhea, basically in CSF rhinorrhea, only one side of the nose might leak one thing. It could be postural, like patient is sleeping. When the patient is, when they're sleeping, that time CSF rhinorrhea might not come. But moment they are standing or they're sneezing or bending, the CSF starts leaking from the brain via dural sinuses through the nose. We also do a litmus test to find out, are we dealing with the CSF rhinorrhea or maybe just a nasal discharge. So if the litmus test is positive, then we are definitely dealing with that. Extra investigation, what we do is MRI cysternography to look for the CSF rhinorrhea and what is the defect. And also we can also go for a MRI brain, the dedicated study involving the frontal and the cribriform blade.
Thank you, ma'am.
Madam, in posterior circulation, the thrombolysis can be given for 24 hours. What is the reason? Whereas in anterior it is for 4 hours.
No, IV thrombolysis, the dead time period is 4.5 hours for anterior and posterior both. But when we are dealing with the posterior circulation, we do mechanical. IV we don't do. IV thrombolysis cutoff time is 4.5 hours only for anterior as well as for posterior. But whenever we are dealing with basilar artery thrombosis and the patient is worsening and patient has come within a time period of 10 to 14 hours and patient has showed a clinical deterioration, so that time we can go for mechanical. So we can give them a benefit of mechanical thrombectomy up to 24 hours when it comes to posterior circulation stroke. Maximum extended we can do up to 48 hours also, depending upon the patient's selective criteria.
Madam, can there be causes of unconsciousness for few minutes due to cardiac ailment? How to evaluate them?
Can you repeat your question, sir?
Recurrent attack of unconsciousness for 1 or 2 minutes. Can cardiac cause be there?
Yes. It's
how to evaluate and investigate.
So this is a very good question, and I think all of us, whoever is attending this today's seminar, maybe all of us in our lifetime practice, we must have come across such kind of patients. So this
I had
kind
one
of
case recent.
Yeah, yes. So what we do is, a patient is older patients, like those who are more than 50 years of age group. So you need to ask few questions to them very clearly. If the giddiness is coming, whether the giddiness is associated with the lightheadedness, some blackouts are coming into the picture. That time, are they feeling that leg power is going low, and suddenly they're losing their postural control, and after that they're falling with the eyes closed, and there is no tonic-clonic movement of the hands. And during that time, whether any sweating episodes are there, with the hands and the palms are getting sweaty or not. So if this is the history, we are definitely dealing with the syncope case. So whenever it comes to a syncope, 80% of the time it is the cardiac evaluation which is needed more than the neurological evaluation. So such kind of patient come to OPD practice. What we do ECG, and we do Holter monitoring, and we also look for neurological causes of syncope, like patient is having tumor at the third ventricle level. So any sudden rise in intracranial tension, patient can lose their consciousness during that time. The closest differential for such kind of episodes, it could be seizures. So history taking is important. Doing EEG is also important because atonic seizures can also present in this way. So EEG is also important when we are not getting other causes and when you still have a diagnostic dilemma for such kind of issues.
Thanks a lot. Excellent.
Madam, thank you so much. And you spoke very well
last question,
pandemic time also. One request before we quit. You keep on taking every Tuesday.
Yes, sir. We will arrange that.
Symptoms, signs, and how to know about the syndromes also. You take serious because I heard you in pandemic also. You are in Terna Medical College, and you spoke really very methodical. You are teaching us. Thank you, madam. Thank you so much.
Thank you. My pleasure. Thank you very much.
Anyone has any question? Yeah, someone was asking.
Yes. I
Yeah.
wanted to ask
Yes,
how
last
to
question.
differentiate TIA and epilepsy.
Yeah, it's a again, it's a very good question, madam. The TI, it's transient ischemic attack. So it is
Yes.
like nothing but the stroke which is coming in the maybe a lesser scale. So the TI would be one-sided again. It will be hemi-sided symptom, one-sided symptom. Acute onset of difficulty in speaking, maybe acute onset of vision loss, acute onset of hand drift problem, or maybe a facial weakness during that time, or a leg weakness, and then there is a recovery. In case of seizures, the seizures, it could be a complex partial seizure or GTCS. Generalized, so we can easily make out complex partial seizure. It will be on, there will not be any weakness or a deficits during the event. The patient can have just a loss of consciousness. TI patient will not have a loss of consciousness. If we are dealing with a partial seizure with unawareness or maybe a complex partial seizure, the patient can have involuntary body movement, maybe a leg twisting or a hand twisting along with the confusion during that episode. Or when we are dealing with just a partial seizure with the intact awareness, we are just dealing with that time maybe only with the one part of the brain is stimulated. So we will not have a paralysis, we will just have an involuntary movement. On the contrary, in the TI, we will have a weakness or a paralysis. So this is the way we can differentiate. Maybe we have to take history more and more than maybe from the more relatives, they can describe it proper way. Then only we can conclude whether it's a TI or a seizure or maybe a partial seizure.
Thank you. Thank you.
Thank
Yeah,
you.
madam. I
Thanks,
think
madam.
questions
Yeah.
are over. Yeah, and as you rightly said, madam, the repeated history taking, that has a very important role in diagnosis of the patient. So I think the time period, whatever you have told, 4.5, less than 4.5 hours for thrombolysis is very important. These are the take-home messages or moral of the lecture or a session. And from the point of view of our family physicians, I have learned from this session that muscle weakness, body ache, as you discussed one case of arthritis. So in arthritis, it is really very difficult to diagnose whether the patient, to whom to refer the patient. And here, neurophysician is definitely going to help us in some cases. And even we have seen one case, headache, giddiness, having a visual defect in the same patient with the CSF rhinorrhea. How to differentiate with the CSF rhinorrhea and allergic rhinitis. That is also very eye opener for us. And even I was very much interested in knowing about this obesity case. You handle it very nicely, and which may lead to idiopathic intracranial pressure, and which can be a very difficult case in some times. And I was not knowing that obesity may also connected to neurological disorders, and that was very fantastic and very eye-opener cases. And thank you so much, madam. And I think all our participants are benefited from this session. And thank you so much. We will definitely have another session on neurological symptoms, which are very much important for family physicians. And I think all are. Thank you so much, all participants. I think 78% participants were there attending the session, and it was a very successful session. Thank you so much, madam, for coming and delivering us such a wonderful session. Thank you so
madam.
much.
Yeah,
Thank you.
you.
Thank you, all participants.
Thank
Thank you.
Thank you very much for joining me. And one last note I want to tell: whenever you don't understand anything about patient, you don't know whom to refer, you can refer safely to the neurologist and you can discuss the case. When we discuss, we have our windows of maybe your diagnosis are still open, and we can discuss, and finally we can get a definitive conclusion or a treatment protocol for a patient. So you never hesitate to refer a patient when you don't understand to whom to refer. Always better to refer to neurologist, because we can neurologist can see the multiple parts of body parts, and we can integrate that picture very well as compared to the other specialty. That is the difference. So thank you all of you for joining me. Thank you, madam, for giving me this opportunity.
Thank you.
Thank you. Thank you. Thank you so much, madam. Thank you.